Okay, so Swadika, good morning. Today we are going to have a wonderful demonstration and lecture from Sarah Gang and Amy Woods, our OHSU rehab team experts on lymphedema and manual lymphatic drainage. Um, Please put questions in the chat. And then there's a part that they're going to ask you to put some thoughts in the chat as well. I think they'll have a question and answer time if you want to raise your hand to ask questions directly, but let's have a lot of participation if we can. All right, Sarah, Amy, it's all yours. I'm your chat facilitator.
Thank you. Thank you for inviting us to speak. It's our privilege. A year ago, we were able to speak on breast cancer rehabilitation and focus on breast cancer related lymphedema surveillance. And now we have the privilege of expanding on that, discussing the principles and applications of manual lymph drainage. So I'm going to spend the first part of our lecture talking about research related to manual lymph drainage. I don't know, whoops, did I do anything?
You're good.
Oh, there we go. Okay. So in here in the United States, we have a fairy tale called Cinderella, and I don't know if you've heard of that fairy tale before, but this is one of my favorite quotes of all time. This is by one of the founding members of the American Vascular Forum. And he said, if venous diseases are the Cinderella of the vascular field, then lymphatics are Cinderella's poor cousin. And I think that's really awesome that you share an interest in lymphedema, because not that many people are interested in it. And I'm really happy that we can speak on it today. Our objectives are to review the current understanding of lymphatic system anatomy and physiology. We want to look at lymphedema incidence and pathology, go through really briefly the stages of lymphedema, a brief history of manual lymph drainage, which is a part or a component of complete decongestive therapy. We want to look at current evidence for traditional manual lymph drainage. We'll look at both meta-analysis and systematic reviews, and then look at the treatment potential using near-infrared fluorescence for ICG or indocyanine green guided manual lymph drainage. We'll go into much more details about that. Personalizing conservative lymphedema management with ICG guided manual lymph drainage, and then look at some devices on the market that assist with self manual lymph drainage at home, which is the FlexiTouch and the Koya DaySpring pump. First, let's take a look. We have a new understanding of the lymphatic system that has evolved from indocyanine green studies of the lymphatic system. First, we know that lymphedema is a chronic protein-rich inflammatory condition of the lymphatic system where the lymph volume exceeds the lymph capacity. And this can lead to pain, infections, loss of function, reduced quality of life. It could be costly and lifelong ongoing treatment needs. It could occur in the neck, in the breast, in the arm, in the genitals, in the legs. Pretty much anywhere where you have a vascular system is where the lymphatic system you can also have lymphedema. So basically, and the schematic on the right was drawn by Dr. Hairu Swami. You'll probably hear about him quite a bit in my message. But you can see the epidermis, dermis, subcutaneous tissue, the deep fascia, and the deep tissue. We're primarily going to be talking about the superficial lymphatic collecting vessels in the subcutaneous tissue. And their primary function is to generate or collect lymph from the interstitium, so the extracellular space. They also have a secondary immunological function that we won't go into in depth in this lecture. What's interesting about these primary lymphatic collecting vessels is they're really only one thin endothelial cell wall thick. So it doesn't take a lot to manipulate them or to even compress them. The collector's role is to absorb and transport of interstitial fluid, and they're really, really small, 0.5 to 0.7 millimeters in diameter. And the lymphatic system pumps for itself. It has an intrinsic pump located within the vessel itself called a lymphangion. and those are found in collectors near arteries. The valves in the lymphatic system are traditionally biased open and only close in adverse situations. So this is our new schematic of the lymphatic system. Hairuswamy has been remapping this since about 2010. So we have more concise drainage pathways to regional lymph nodes. This is called the lymphosome concept. Again, he remapped this because early anatomists from 1874 on used mercury to study the lymphatic system, which we know is toxic. And so in 1874, they were like, oh, this is it. This is the lymphatic system. And this is how it all goes together. And then Dr. Hairuswamy in 2010 started using indocyanine green. And he said, no, it's more of a lymphosome concept where you have watersheds that drain to regional lymph nodes. So it's divided into a superficial and a deep lymphatic system separated by deep fascia. They actually think that it's unlikely that the superficial and deep lymphatic systems communicate with each other. They think the deep lymphatic system, which is closer to, which is within muscle and near bones, is likely too high of a pressure for the superficial system to drain into. Anyways, as I said, there's two types of lymph nodes, regional and interval. Regional drains watersheds. So like those would be your axillary lymph nodes, your inguinal lymph nodes, your popliteal lymph nodes. And the interval lymph nodes, actually, I'm sorry, would be more like your popliteal and cubital lymph nodes. We don't know a lot about the interval lymph nodes. Basically, lymph drains through them, but we don't really know exactly what their functions are and how they differ from regional lymph nodes. So we still need to do more studies on that. But you can see the different regions that are known as lymphosomes that drain specific watersheds. When this is obviously a normal, healthy lymphatic system, and when you see changes such as lymphedema, you actually can see with indocyanine green, you can see dermal backflow, and that's a sign of lymphatic fluid congestion. So there's a vessel that's not patent that's draining retrograde, so distally, into the interstitium, and dermal backflow can work as a detour route. There's other lymphatic channels that you could potentially push that dermal backflow to, and that's called collateral formations. But collateral formations don't always prevent lymphedema. I love this quote. This is found on the Lymphatic Education and Research Network.org. All of these are referenced, the references are provided, but it's interesting to me up to 250 million people worldwide have lymphedema, with 10 million estimated in the United States. So that's more than HIV, Parkinson's, multiple sclerosis, and ALS combined, muscular dystrophy and ALS combined. So normal structure and function of the lymphatic system can be altered by congenital diseases such as primary lymphedema, lymphatic tumors, malformations, trauma, cancer, radiation, or surgical injuries are the result. Cause secondary lymphedema. Every day, children are born with incurable lymphatic diseases, tumors, and malformations, leading to life-altering and sometimes fatal complications. And it's interesting to me, and you'll see different statistics that we'll talk about, but they say up to 30% of breast cancer survivors acquire debilitating lymphedema. And but those, and I have some statistics in just a minute about those who are treated with prostate, ovarian, head and neck cancers, and melanoma. They also think that people who suffer debilitating injuries, like extensive injuries, trauma, infection, and burn pit exposures, are also at risk for lymphedema. So this diagram is on the, I think this might be in one of the articles that we gave you to read. This is the incidence of lymphedema. It's also on the website for the Lymphatic Education and Research Network, and it breaks down secondary lymphedema. But I want to talk really briefly about primary lymphedema. Primary lymphedema is you are born with an incompetent lymphatic system. So that means not enough lymph nodes, extremely small vessels, or the vessels didn't develop. But there's 3 times at which primary lymphedema could occur or seen across the lifespan. So if someone is noted with lymphedema at birth, that would be congenital lymphedema. If they're noted with lymphedema from like adolescence to maybe age 35, that would be lymphedema praecox, and it's all primary lymphedema. And if they're noted with lymphedema after the primary lymphedema after age 35, some people think it even might have to do with like hormonal changes, but after age 35, that would be lymphedema tarda. And out of all lymphatic diseases in the US, I'm sorry, in the world, primary lymphedema probably only accounts for 8% of lymphedema. So it's really small, which is why we spend a lot more time talking about secondary lymphedema, which is most often cancer-related lymphedema. And research, again, this was kind of published, and it was published in 2008. But I really think lymphedema is an under-recognized disease that we don't have a good way to study how many people in the world actually have lymphedema because most practitioners don't recognize it. But they say people with breast cancer have about a 20 to 30% chance risk of obtaining lymphedema. Malignant melanoma is 6 to 29%. Again, it's a huge range because we don't really know. We don't really study it that much. Gynecologic cancers is really high. They're estimating that 49% of people with gynecologic cancer end up getting lymphedema. I think by the time that gynecologic cancers are found, the surgeries are pretty extensive and radiation is pretty extensive, and that leads to a higher incidence of lymphedema. Urologic, the estimate is 3 to 8% of people with urologic cancer treatment will get lymphedema. And then you have your soft tissue sarcomas, and the estimate there again is 3 to 30% of people will get lymphedema after sarcoma treatment, cancer treatment. So lymphedema, secondary lymphedema, is not just because of cancer treatment. And cancer treatment, again, is a result of radiation or surgery, but secondary lymphedema can also be acquired by severe burns, venous trauma, extreme wounds in the extremities, and even some people think maybe even pharmaceutical use, like sirolimus after organ transplants, can cause an onset of lymphedema. So this breaks down kind of the trauma-related iatrogenic lymphedema issue, which we see most often here in the US is probably like related to a venous insufficiency here in the US, but this breaks down other incidences. All right, so here's the stages of lymphedema. And I included like 3 different stages, but I'm only going to really focus on one. But you can see if you look on the right of your screen, opposite day. If you look on the left of your screen, the stages of lymphedema, you can see there's a Foldy stage description, MD Anderson head and neck description, and then this International Society of Lymphedema. They all have their stages. Typically here at OHSU, we use the bottom left stage because we go by what we see. So subclinical, no overt symptoms. There's impaired lymph transport. There's subtle subjective symptoms. People are like, my skin feels tight, my limb feels heavy, my sleeves don't fit right. I don't know why. I can't see swelling, but something feels off. Stage 1 is called the reversible stage because it reduces with elevation, and oftentimes we'll see pitting edema. In stage 2, it's considered the irreversible stage because it no longer reduces with elevation, and it only partially improves with treatment. We're starting to see a little bit less pitting at this point because the pitting edema in the extracellular space is turning into a fibroadipose tissue. And in stage 3, we really start to see the morphologic skin changes associated with elephantiasis, and pitting is completely absent because fibrosis is present. However, right in the most accurate staging right now is using indocyanine green. And indocyanine green is a safe tracer so that people are not exposed to radiation. It's a biofluorescent tracer. It's injected subdermally, and it's very low cost, so it's easy to study. So this is Macquarie University in Australia. I think this staging started with MD Anderson, and they took it a step further. But this is where Dr. Hairuswamy practices. And you can see when they inject the indocyanine green, they actually use infrared light to track the fluid uptake in the lymphatic system, which is really fast. And you can see in stage 0, all of the lymphatic vessels are patent and open. There's no dermal backflow, and the lymphatic vessels are contracting normally. Then when you get to stage 1, you see you lose a few vessels. A few of the vessels become impatent. You can see there's slightly, see how it looks in stage 1? It looks a little cloudy in the mid forearm. That's some dermal backflow that you can see. And then the vessels become less contractile. In stage 2, you see even more dermal backflow. You can see the dermal backflow at the cubital crease. You can see it on the ulnar side of the forearm. You can see the dermal backflow in the hand. So you're seeing a lot more dermal backflow, and you're seeing less contractibility of the lymphatic vessels. And then in stage 3, almost no vessels are patent. You have a ton of dermal backflow. There's very little contractibility of the vessels. And then when you get to stage 4, it's absent vessels. And in stage 4 is when most of that extracellular fluid has turned into a fibroadipose tissue, which is essentially scar tissue, right? And there's no amount of manual lymph drainage that probably will assist with breaking up that scar tissue. And you can't make the vessels that are scarred down patent again, basically. A lot of people with stage 4 are often offered some type of suction-assisted lipectomies, which may help improve their quality of life. But the goal of therapy is to see people in subclinical lymphedema stages so that we can prevent the progression of lymphedema, so that we don't end up with impatent vessels that have insane amount of dermal backflow. All right, so manual lymph drainage is one of 4 components of complete decongestive therapy. Here's Dr. Hairuswamy. I had permission to take this picture. This is at the Harvard Lymphedema Symposium in 2018, and he's demonstrating the use of ICG, or indocyanine green, with us on a fresh cadaver that he actually harvested. So it's kind of cool that we're able to see this. But manual lymph drainage started in the 1930s, although remember in the 1870s is when they first mapped the lymphatic system, and then they left it alone for like 60 years. They had no interest in the lymphatic system until the 1930s, when Dr. Vater, he was a massage therapist, and he noticed that he could use skin stretching massage to move lymphatic fluid out of affected extremities. And then in the 1960s, the first manual lymph drainage training school started in Germany, based on Vater sequences. And that was with a physician, Johannesburg Asdonk. And then the physicians who really expedited lymphatic studies in the late 1900s was the Foldys. And they were a married couple, both Hungarian born. They immigrated to Germany, and they started and established the very first clinic that treated lymphedema. They're the ones that coined the term complete decongestive therapy, and they came up with the 4 components, including manual lymph drainage. So that lasted until the early 2000s, when Dr. Hairuswamy was like, wait a minute, we're using indocyanine green to find the sentinel nodes in breast cancer. So that was the tracer they used to find the sentinel nodes. What if we used indocyanine green to map the entire body lymphatic system. And so that's what he started. He was trained in Japan as a reconstructive microsurgeon. And then in 2009, he joined MD Anderson in Texas. He started out with an animal model using ICG. And then he came up with the lymphosome concept, which was remapping the lymphatic system. And then by 2015, he was recruited to Marquette University, and now he still currently works with the Australian Lymphatic Education and Research Treatment Center. So he decided that let's rename the lymphatic system into the lymphosome concept, and maybe there's a better way to treat lymphedema. Again, here's traditional decongestive therapy. It's 4 parts. It's 2 phases. There's an intensive phase and there's a maintenance phase. So both phases have the same components. They're just a little bit different. And in each phase is always manual lymph drainage. And we always have skin care, we always have exercise, and we always have compression. In all of the phases, it just changes a little bit. Maybe we use compression bandages instead of compression garments. And I think this is going to change eventually as well, but this is our current complete decongestive therapy schematic. Okay, so if we go onto databases like PubMed or the Cochrane database, and we search for meta-analysis and systematic reviews, looking up what is the evidence for manual lymph drainage in lymphedema after breast cancer surgery, or how do you reduce the risk or manage lymphedema after any type of surgery? A lot of the patients are related to breast cancer. That's the largest group of people that tend to get lymphedema after treatment. And so meta-analysis, they take all these randomized controlled studies and they combine them all together and they look at the data, and guess what they find? All of these meta-analyses say the same thing at the end. More studies are needed to confirm the effectiveness of manual lymph drainage, but they're not using indocyanine green at this point. None of these studies use indocyanine green to study the effectiveness of manual lymph drainage. So they all say, hey, we're not done yet. Some of them say there's no effect of manual lymph drainage. But as a lymphedema therapist, I can feel effects, and I have anecdotal evidence that my patients do feel improvement after manual lymph drainage. But there's no studies that support it until about 2011. There's a group out of Texas that came up with this pilot study. And it just started with a small amount of subjects, so 10 patients with stage 1 and stage 2 lymphedema, and 12 people with normal lymphatics. And they looked at injecting indocyanine green, and what happens when they inject indocyanine green, they looked at, does the lymphatic system contract faster and more successfully with manual lymph drainage. And what they found, that they should not only show that contractile lymphatic function improved after a single session of manual lymph drainage, also demonstrates the feasibility for using near-infrared fluorescence imaging to monitor the response of treatment. And we're going to take this even a step further, but I want you to watch this video. It's pretty cool. So at the very start of the video, you're going to notice, and it goes really fast, you're going to notice that at the bottom left-hand corner, it says before manual lymph drainage, and then it'll say during manual lymph drainage. And I want you also to look at the time in the upper left-hand corner and see that this is really sped up super fast. But what is interesting to me, when I'm going to start this video, is that you can see the lymphatic vessels contracting, and this is a foot. Hopefully you can see the heel, and the heel is kind of on the right side of the picture. You can see the ankle, and the toes are on the bottom of the picture. They're off the image. But what I really, really want you to notice is that this person they're starting manual lymph drainage, and you can see proximal contractibility of the lymphatic system even before they get to that area. So it's kind of cool. But here we go. Let's see if it works. There's no sound. Again, you can see that the contractile units are stagnant. Now they've started manual lymph drainage to the foot, and you see almost immediately even proximal drainage of the lymphatic system. And it's really, really fast. So they're not even working on the foot. They're working on the toes right now, probably the plantar surface of the foot, maybe a little bit of the dorsal surface. As they're working from distal to proximal, you can really start to see the lymphatic system contract. You can see lymphangion activity with manual lymph drainage and indocyanine green. So it's kind of cool to see this. And the link to that is in the references as well. All right, so how did Dr. Haruswamy take this even a step further? And I think this is one of the papers that we sent as well, the articles we sent for you to read, which I think is so interesting. He originally used indocyanine green to study the lymphatic system, and then he said, hey, I think we can actually personalize manual lymph drainage with indocyanine green. And so indocyanine green, again, it is injected subdermally. There's relatively no pain. It uses real time. It's fast. Also, it's really uptake fast by the lymphatic system. It uses real time visualization of lymphatic fluid movement through the patent lymphatic vessels. It visualizes area in the extremities where a dermal backflow is occurring. If he studied the superficial lymphatic system versus like the pre-collectors. Remember, pre-collectors are in the epidermis. So he noticed that if you really wanted to activate the superficial primary lymphatic collectors, that you need to use a slow, firm pressure to bridge the fluid from areas of backflow towards where there's common drainage areas or where there's lymphatic vessels that are noted to be open or patent. And he said in his article, look, guys, stop spending therapeutic time on traditional manual lymph drainage pathways that likely don't exist. He said, really work on pathways that are more likely. So they studied in this study, they looked at 275 people with the 5 stages of MD Anderson lymphedema, and they broke it down. And what they found was actually quite interesting, that people in stage 1 and 2 lymphedema are more likely to drain to their normal pathways, which would be the axilla. And they found that people in later stages of lymphedema were likely, so stage 3 and 4, were likely to develop compensatory drainage patterns. So if you're treating someone with stage 1 or 2 lymphedema, then don't waste time treating the contralateral axilla, because it's unlikely to go that way, even though that's the traditional manual lymph drainage pattern. And then, so therapists who don't have access to indocyanine green fluoroscopy should focus most common pathways identified. And so I really, really like that this breaks it down. And some patients, they come in and they say, hey, I followed a video on YouTube, and YouTube says that I need to massage the ipsilateral inguinal lymph nodes. And I usually come back to this article and I say, like, hey, look, in stage 1 and 2 lymphedema, the ipsilateral inguinal had 0% of lymphatic drainage, indocyanine green lymphatic drainage. In fact, the ipsilateral inguinal has 0 lymphatic drainage, even though that's one of the traditional pathways that lymphedema therapists massage towards. There was 0 indocyanine green that tracked to that region. All right, so here is lower extremity. And again, what I like pointing out with the lower extremity, and if you study these numbers, you will see that in higher stages of lymphedema, so stage 3 and 4, lymphatic dysfunction tends to have a higher chance of draining to a compensatory location. So that compensatory location could be like the posterior hip or posterior thigh. It's really unlikely. They saw some drainage to the ipsilateral axilla, but it was very, very minute. And they say that it probably needs additional studies. But more than likely, from the leg, if we're going to be working it with someone with stage 1 and 2 lymphedema, then it's going to drain to the same side inguinal region. It has the potential to cross to the contralateral inguinal region, and then maybe a little bit of the popliteal region as well. But more than likely, I think if you look at the article, 67% of the time, 50, maybe it's 53 percent of the time, um, excess lymph fluid is going to drain to the same side, the ipsilateral inguinal region. Um, but it's interesting because again, this is another interesting part of this study, is they found that people or individuals with cancer-related lymphedema were more likely, 8 times more likely, to have a compensatory lymphatic drainage pattern than individuals with lymphedema due to other causes like trauma or venous insufficiency. And again, as the MD Anderson stage increases, you're likely to see less drainage to the ipsilateral inguinal and popliteal lymph nodes. It develops as the lymphedema stage increases, more compensatory patterns are established. All right, so where does that lead us now? So what do studies say now? So this was published in 2023, and this is a group out of Belgium, and it was 4 large hospital systems in Belgium. And they took 3 control groups. They took a group that received indocyanine green guided manual lymph drainage, traditional manual lymph drainage, and placebo manual lymph drainage. And they had 65 patients with stage 1 or stage 2 lymphedema in each group. And they wanted to look, they looked at quality of tissue, and they based it on pitting edema. They looked at volumetry, so where you put a limb in water and you measure the displacement of the water. And they also looked at circumference measurements. Each person apparently in the study also received indocyanine green injection just to look at where the dermal backflow was. And what the study found, and again, it was published last year, was they were unable to demonstrate any added value of manual lymph drainage for superficial lymphatic architecture. But this is where you look at the study and you read it, and you skip over the abstract and you read it in depth, and you're like, wow, this study has a ton of holes. The study is not complete, even though they were published. One, their water displacement and circumference measurements are not a good indication of tissue quality. Size, if you look at staging and dermal backflow, it isn't correlated necessarily to limb size. You can have really small limbs that are fibrotic. So some people, maybe they wear compression, but they don't do anything else, and they have small limbs, but they have super fibrotic limbs. And so really, are they going to show stage 1 or 2 in lymphedema if that's the case, since they're not using any bioimpedance to study these clients? So we have no basis on if tissue quality improved with manual lymph drainage, because they didn't really study that. So I actually, at first I read this study, I was a little bit disappointed with the results. And then I realized, look, this is not a complete study. And guess what? I'm not the only one that thought that. Because when I did a further study and I was looking at clinical trials in the US, the University of Florida is actually currently requesting people. They're currently recruiting, or they're going to start recruiting soon, people to start a study here in the US using manual lymph drainage, comparing indocyanine green guided manual lymph drainage to traditional guided manual lymph drainage, people who underwent axillary lymph node dissection. And when I went through, if you look up the study, they actually use bioimpedance to look at tissue quality and to measure if the person limb circumference is not a good measurement of improvement. So they're using indocyanine green and bioimpedance to study the tissue quality, which is pretty cool. So studies are still happening and they're ongoing. And I think that we still need to look for more research. And so, here in the United States, this was a YouTube video based out of the Boston Lymphedema Clinic, which I think they're the only ones in the US using indocyanine green to guide manual lymph drainage. The link to this YouTube video is also in the references. This is the largest lymphatic clinic in the United States, which is actually combining Harvard Medical School, Boston's Children, and Beth Israel Deaconess. It's all right there in the same location where those three centers are. And they sent two therapists and a nurse practitioner to the Marquette University in Australia to train with Dr. Harusuami and his associates. And the reason why a nurse practitioner needs to attend is they are the ones here in the United States, we're not allowed to do injections. We're not trained for that. So they have a nurse practitioner who injects the indocyanine green. She's the one holding the infrared light. And the therapist is the one seated, and you can see that she's working on a gentleman's leg, and she's kind of looking over his shoulder because she's looking at the projection from the light onto the screen. So she's looking at the lymphatics in his leg. She's particularly, so this is real-time manual lymph drainage. And she is looking to find areas of dermal backflow. And then she's looking for linear channels to direct the backflow to the lymphatic vessels. And when in real time, when they're doing this, they actually give each patient a handout of their map. And they say, hey, this is where your area of backflow is. This is where we want you to push the fluid towards. These are your compensatory vessels that are patent and available. And they're finding that people who have their own specific tailored manual lymph drainage map are more compliant or adherent to their home management program than those clients who they train with the therapist. They're given a handout, and they don't really feel a difference. They don't really know. But my therapist said to do this, and this is the sequence I need to do. But with these particular patients, we're now starting to be able to say, hey, this is where your lymph is draining to and from. So I hope sometime, this was actually popped up in my queue kind of in 2018. We had a lymphatic surgeon here at OHSU, and I was like, hey, let's go to Australia and get trained. And then COVID happened, which I think is everybody's story. But who wants to go to Australia now? I'm so ready. But it's interesting because as Amy and I are advanced lymphedema practitioners, we were chatting about how, you know what, I think that as a practitioner, we can probably feel areas of dermal backflow. I think the skin is more taut. You can feel a lot more of a greater density in those areas. And I think that as therapists, we tend to spend more time in that area. And usually I'll tell a client like, hey, you feel really full to me, to your posterior elbow or posterior medial elbow. Why don't we focus on this area today? So I think as the longer you practice, you probably feel it more, but it's really nice to have empirical evidence to reinforce that with an indocyanine green guided lymphatic drainage program. And here, Connie, is kind of where I wanted some help. But here in the US, we have compression pumps, and there's an entire market of lymphatic pumps that are very costly. And some clients think like, hey, if I get a lymphatic pump that mimics manual lymph drainage, I can take care of this at home. I don't need a lymphedema therapist. And so what is the traditional most of them are not compliant though. They're anyway, and we'll go through this in a minute, but there's a very traditional pneumatic compression pump, which is called Tactile Medical. They make the Flexi Touch pumps, which are multi-chambered pumps that inflate in a very specific sequence, like traditional manual lymph drainage. People can use these devices at home. A lot of times people might feel a certain analgesic effect. They might feel like it's helping. They might feel like, hey, if I do this every day, I'm going to prevent the progression of lymphedema. But in the end, most people tend not to be compliant with these devices at home because they're bulky and they don't travel with them. And once you strap yourself in, you're in there for 60 minutes. So you need to make sure that everything you need is within reach. You need to make sure you use the bathroom beforehand. So these devices have very low adherence on the market now, first of all, and then I kind of want you to add in the chat. The new device is the DaySpring non-pneumatic compression device that mimics manual lymph drainage. And tell me in the chat, what do you notice differently? What's different about the DaySpring non-pneumatic pump compared to the Tactile Medical FlexiTouch pump? Has anybody noticed the primary difference? Sorry, Connie, are you there?
Yep, yeah, it's
Any,
size and portability.
yes, yes, what else?
Come on, everyone. Throw it in the chat.
There's something really evident. It's startling actually. Um, that basically people who use this pneumatic pump by Tactile, they're sedentary. They're not moving for 60 minutes, which traditional lymphatic therapists think that compression coupled with exercise is the standard, the gold standard of practice. So why would we want our patients to be sedentary, right? What the manufacturers of DaySpring noticed was that, hey, what if we developed a coil system that mimics manual drainage? So it's non-pneumatic. It uses a metal coil that's kind of like a spring that contracts that while a person is walking or doing their ADLs or doing their daily exercise routines. So instead of being sedentary and being a passive treatment, we now have this device that's just emerging onto the market here in the US that's active. So someone is actively using this device. And preliminary studies are showing that these people tend to be more compliant with the device because it's not interfering with their activity. They don't have to plop themselves down for 60 minutes and just be a couch potato. They actually can get on with their life and be active. So I see the way that we're emerging. And interestingly, I think the financial cost of these devices is pretty similar, and insurance is reimbursing for these devices very, very similar here in the US. So I think the trend is going to be getting away from a passive pneumatic pump and trending towards this non-pneumatic active compression pump. All right, so if I am going to give one of my clients a handout, on the sequence that I want them to do for manual lymph drainage, this is what I would give them. And I have actually included the full sequence because I know that they're going to go to YouTube. I know they're going to say, hey, I'm supposed to pump on my opposite armpit. But it's not on the list, but it is on the list. And I always fully acknowledge, like, look, this is what you're going to see on YouTube. You're going to see therapists telling you to massage towards the contralateral axilla that did not receive treatment during cancer treatment. However, emerging studies, studies published in 2018 are showing that it's very, very unlikely in early stages of lymphedema that lymph will drain to the contralateral axilla. So I have, when I give my clients these handouts, I am acknowledging that that's what you're going to see if you look this up. However, it's not supported by research at this time. And so I've left them on as the sequence, but I have uh, I've crossed them out on, so they know that I'm acknowledging that pathway potentially exists, but it's unlikely. So this would be the sequence that we would use for upper extremity manual lymph drainage that I would give a client to do. And then here is what I would actually give someone for lower extremity manual lymph drainage. And I think, and usually I would draw arrows on the human body in that diagram, and I might even label it with numbers. And we always start in proximally. Remember, a quick lymphatic anatomy is the lymphatic system drains to the vascular angle between the jugular and the subclavian, right there at that venous angle. The lymphatic vessel, the thoracic duct, re-enters cardiac circulation right here above the clavicle. So we're always going to, the idea is you need to, if the lymphatic system is like train tracks, you have to get rid of the trains at the station, the train station. So the proximal decongesting before you make a way to clear a way for the train tracks to drain to the train station, which would be here where it empties into the cardiac circulation. So we always start, it's a negative pressure system, and we always decongest proximally to distal. But anyways, I'm going to have Amy go. I'm going to turn it over to Amy so she can go ahead and demonstrate this for you. Any questions before we transition?
No, I was just wondering on that portable, wonderful device, do you know the price? If
You know, I tried to get the vendor to narrow it down for me. Let me see if I can go back to it. I met with the vendor. Um, and so I know that the Flexi Touch can run somewhere around like, I know three to $7,000. A lot of insurances cover it. But they told me when I met with the rep for Dayspring that it was similar, the cost was similar to Tactile, but they wouldn't actually tell me the price.
and is it only single use or can it be used with other patients?
Um, that's a really good question. I know there are some lymphedema clinics that do use it with patients, and that is part of the treatment. So if you're seeing bilateral lower extremities, maybe on bilateral lower extremities with bilateral lymphedema for a treatment session, you might put the pump on one leg and do manual lymph drainage to the other. Some clinics do that. And so yes, you can alter it to fit a variety of body habitus.
Thank you.
Yes, but I just want to say I think the future of lymphedema and lymphedema clinics is using indocyanine green guided manual lymph drainage. And someday I hope in the US we have more than one site on the East Coast that's doing this. On the West Coast, we don't have anyone doing indocyanine green guided manual lymph drainage. Maybe OHSU can be the first.
That's what I think. And I think I was going to ask you guys in 2025 to go to Thailand. So can't you just go to Australia from there?
Let's go. I'm ready.
Okay.
Yes, sign me up.
Sounds good.
All right, I'm going to turn it over to Amy.
Oh, one question. What do you think about stockings?
Oh, it's gold standard. Compression with exercise is gold standard of treatment. So, I love when I mean, even if someone with venous insufficiency, using a compression stocking is necessary during exercise because it's the you have a dual force. So you have the lymphatic system that is pumping against muscles pumping, and then you have a superficial force, which is actually the compression garment, and so they're all pumping against that superficial force. So it's like a dual force pushing the fluid proximally. So compression is essential. right, so I'm gonna stop sharing my screen, maybe. Has it stopped? No.
It's still
Okay,
there.
here we go.
Perfect.
So Connie, I'm just curious, how many practitioners actually currently do any kind of manual lymph drainage in their clinics now?
Okay, so in the chat, there's over 203 participants. You guys just won the golden number of people participating. So you know this topic is so interesting. In the chat, please write if you're doing it. Manual lymphatic drainage. This is for points.
Yes. Oh, I see.
Oh, Dr. Piapat says walking the pool can reduce lymphedema.
Aquatic exercise replaces compression because you have aquatic pressure placing the same type of compression on the limbs. So yes, you can replace compression with aquatic pressure. And it's a great extra. If we have a client with lymphedema and I'm like, oh, do you have access to a pool? Because that would be my preferred exercise for you.
Anybody else? Don't be shy. You can actually even come off mute. Nobody's doing it. Is that why these two have to come to Thailand?
100%.
So there's so many different theories out there, techniques. So when we get trained, it's a 10 days of certification in lymph, certification with the complete decongestive therapy, learning how to bandage, and learning how to manual lymph drain. So it can be up to days of actually practicing. So what we're going to show you today is just kind of a basic how to move the fluid. But you probably will, as Sarah mentioned, be able to go on Google or YouTube and find millions of different videos of different techniques. Basically, the takeaway is the opening up of the channels that Sarah mentioned proximally. And because things are very superficial, you want to just really do a light skin stretching when you're moving the tissue. And again, we've been doing it for so long, I think that instinctively we kind of can feel and know what to do with our hands. And so again, what we show you today is going to be very general, but you might most likely find that if you feel an area that's thicker, harder, more swollen, that you might end up spending more time there, and then moving around to the rest of the system. And so again, I'll show with the both sides, even though we really want to focus on the same side that we drain on. And I'll do my best to show, again, having been there and showing you what it feels like on your own skin and what to do. A lot of times with the lymphedema, I find, especially with breast cancer patients, their tissue gets to be very thick and fibrotic. So traditional manual lymph drainage is that really soft, gentle skin stretch where you're redirecting the fluid. But a lot of times I'm in releasing trigger points, knots that people get, opening in their shoulder, doing a lot more shoulder joint mobilization. If the tissue is fibrotic, I'm getting in there and doing deeper work. I think probably with head and neck cancers, when we see that really thick fibrotic area in the face and the neck, I spend a lot of time going deeper than what the traditional on just the top of the skin is. But when patients leave, they're significantly smaller and reduced. So again, like we'll just kind of do a general overview, and then it'll be patient dependent on, you know, how much time you might spend in one area or not. Okay, let me figure out this computer here, because we have
We're gonna move videos. And then I noticed that there's a question in the chat, which is actually a really good question. It's what class pressure stocking is suitable to prevent or treat stage 1 lymphedema. So stage 1, again, there's just very slight dermal backflow. A lot of the lymphatic channels remain open. I feel like this is a loaded question, by the way, because it's a hard answer. But I want to choose compression that my patient is most likely to be compliant with. So if it's an upper extremity and they have stage 1 lymphedema, most likely we're going to recommend a 20 to 30 mmHg, which is technically a class 2 compression garment. So 20 to 30 mmHg, millimeters of mercury pressure. So that would be for stage 1 lymphedema. Now it's interesting because they say that the leg lymphatics are so much more distal, so much further away from the heart, that patients with lower extremity lymphedema need to have a higher class of compression. So like 30 to 40 mmHg would be the standard compression for lower extremities. And those here in the US can run anywhere from, I don't know, $90 to $150. So then I'm having this client purchase a 30 to 40 mmHg compression garment, and then they come back and they tell me, like, it's so hard to put on, I'm not going to wear it. And that it completely defeats the entire purpose of compression. So most likely for lower extremity, I might even choose a lower grade compression for the legs, even though it's supposed to be higher. So I'd probably put a lower extremity in a 20 to 30 millimeters of mercury compression garment, so that they would be more compliant. And I'd say, hey, I'm doing this and I want you to be more active. I need you to walk at least 30 minutes a day. I need you to get in the pool at least 3 times a week. So that's a very good question. Thank you. All right, so is it okay if we transition to a different camera? So,
okay, thank you, Sarah. Okay, at this time, we would like to capture the picture and then we'll send the picture to the Thai PT Council. Okay, please. Okay, thank you very much.
yes.
I think we have to rotate that. Oh.
Okay, so if we set the camera down a little bit, there we go.
Can you see the camera? Is that okay?
Let me do this.
Okay.
And then you have some sound.
Okay, so go ahead and stand here first. Let's see. Is anybody with other people with their partners or anything? Because you can kind of practice as we go. So if a patient comes in, first thing that I want to do, I have already done my intake. I really talk about posture. And a lot of our patients that we see have breast cancer. And so I kind of talk about why what we're doing is important and for them to continue to do their work when they don't see us. So if they come and they get manual lymph drainage and they don't go home and wear their compression or do their exercise or watch their posture, what I do in our session isn't going to be, it's going to be short-lived. So I like to educate them as much as I can. So I'll always kind of look and see how rounded somebody may be in their shoulders. And I explained to them, if this was a breast cancer patient, if they had surgery and radiation, why it's so important that they really work on getting their shoulders down and back and doing their exercises long term. Kind of explained that this tissue was radiated, there's scar tissue here, and over time that tissue is going to want to pull their shoulder blade forward, which then can limit their range of motion. Pull their head forward and then give them neck pain. If there's somebody that works on a computer a lot or has some kind of hobby where their arms are in front of them, I just re-educate them on how important it is to keep this here. The head comes forward, it's like a 13-pound bowling ball, and if it's here and I'm rounded, it's gonna make me tight through here, it's gonna make me tight in my neck. So I kind of use as layman terms as I can with telling them that this tissue here was radiated, it gets tight. Usually the radiated field is through here. It can bring your shoulder blade forward this way, which then can get them tight through here. So a lot of times they come and they get, they have a lot of knots or trigger points through here. Then I explain if their shoulder blade is rounded and they're forward, they get tight through here a lot. And so the more their shoulders are down and back, it creates more slack here, and then they're more apt to have less trigger points in here. These will get a little bit more relaxed, and their shoulders and things won't be living up here where their ears are. And a lot of times just taking a couple minutes and just explaining, they're like, oh my gosh, I had no, you're right. I'm tight through here. I have these knots and things through here. So when I can show them in the mirror, if there's any discrepancies, if they are forward, that they can then see themselves in the mirror, then they are more apt to kind of watch their posture, do their stretches, do their strength exercises. They're more apt to change their computer posture at work. Just by kind of taking that, first few minutes before we even do anything in that first evaluation. So then that's why what we do with the manual lymph drainage, where the video was, talking about the light skin stretching. I'll spend a lot of my time working on these trigger points through here, working on them in the back. And with the breast cancer patients, they get really thick and fibrotic in here and through here. So I'll do a lot of rib work and a lot of other shoulder joint mobilization. So it's not going to be just that soft skin stretching. So when you do the skin, it should just be like a skin stretch. That's just kind of how much pressure that you want when you're just doing the draining and you're doing kind of working on the swelling. If somebody has a knot like that, I'm going to be in working things a little bit deeper and moving things around more. So that's kind of what will happen up in here, maybe in here, or wherever I feel. So if I feel somebody comes in and they might have, kind of a pretty swollen hand, it'll be more of that gentle skin stretching where I'm kind of moving things. But then if I feel like, oh, wow, there's like just some trigger points here or some other things here, I'll spend a little bit more time. So you just have to go by kind of what your hands tell you once you're working on somebody. So go ahead. Just if you have, Connie, if there's questions or anything, or they want to see something more, just let me know. Otherwise, I'm just going to kind of go.
You guys, I had to run for a minute, but did you read that? I had a lot before. I had LDT before, but after about 5 minutes, I felt nauseous and dizzy. What could be causing this?
During like actually having, they were receiving the manual lymph drainage.
Yeah.
Sorry, go ahead. So, what I think is interesting, I'm not sure which one. Our clients need to drink a lot of water and be hydrated before we work on them. And I wonder if there's an issue with low volume, like maybe somebody's hypovolemic, and that could be contributing to the dizziness. Maybe they're dehydrated because we are a moving fluid. And ultimately, the fluid is ending up in the cardiovascular system. It is being sent through the cardiovascular system to the kidneys and excreted out in the urine. Sometimes my patients do say that they have more consistent bowel movements as well, which I can't relate to any pathophysiology, but there is usually an excess volume of urine. So people need to stay hydrated during manual lymph drainage. And that could be why someone felt dizzy.
I would also ask if the patient was having chemo? Are they anemic? What are their blood counts? Could it be something related chemically that they're feeling dizzy? What's their blood pressure? And so investigate other potential issues that could have been causing the nausea and dizziness, aside from just us moving lots of things around can create that as well. Any other questions?
Yeah, how should we use the pressure in MLD?
It's a very gentle, like you're just putting your hand on, let's say, your arm, and you're stretching just the top of the skin. It's more of like a tissue skin stretch for just like the drainage part of it. But we can use a lot of stationary circles on the skin. You can scoop the skin. You can do rotary on the skin. You can, yes, circles, and that kind of is kind of how you would move it, but it's a very soft, gentle pull, skin stretch pull.
Yeah, and you do want to get to that subcutaneous layer where the primary collectors are. But if you're massaging muscles, if you're applying enough pressure for soft tissue or muscle massage, then you're actually compressing the lymphatic vessels that you're trying to activate.
So they said about 2 grams or more.
So, you know what's interesting? Sorry. That's a good question. But you know what's interesting, when using endoscending green manual lymph drainage, they noticed that it was only really 1 to 2 millimeters deep into that subcutaneous space. So 1 to 2 millimeters is actually really tiny. So I suspect, since we use a different measurement system here, we use pounds. Grams would probably, I think when you're talking about grams, that's probably perfect.
That's it.
Everybody see okay?
It's
So
perfect.
So I like to use pretty much most of my hand because I'm going to cover more surface, and I'm kind of going back and down when I start to work on the neck, and then when I work around the clavicle to kind of open up those proximal channels first. You want to try to get the pictures that I sent kind of show everything that's in the head. So I kind of also get right at the base of the skull, and it's just a gentle stretching back and down again, just that little bit of pressure right at the surface. Again, the more that I can just use my whole hand, I'm going to cover a lot more. Then again, for me, I like to use my hands, and so I kind of do the clavicle. And here it's kind of like a rotary stationary circles, kind of going down and back again, thinking that we're kind of opening up everything that's here at the head and neck. Kind of go out and down over the tops of the shoulders. And I'm sure there's probably people out there that give you a set number, do this 10 times. I don't know, would you say? Probably roughly 10, you know, starting out, if it's your first time and you just need that kind of numbers, I would, you know, maybe do this 10 times at the neck, do it 10 times here, 10 times at the top of the shoulder. Again, if I see somebody and they have a lot of fibrosis already or scar tissue, or they're swollen here, again, I might just spend more time in this early stages. And then, is there a question? So then the sternum, and again, kind of the top here, and then opening up. So you kind of are getting pretty much from here to here. Then we kind of work in the abdomen. Again, there's a lot of vessels, drainage areas in the abdomen. And so again, we want to direct everything kind of through here. So again, for me, I kind of want to follow I stay on the right because I want to follow the intestinal tract. And before COVID, we used to do a lot of having the patient do a lot of deep belly breathing in and out to kind of help pump. Honestly, since COVID and people wearing masks and things, I probably don't do that as much. So I'll probably spend more time in the abdomen, just kind of massaging through, get sides here. And again, for time, you know, maybe a good 10, I'll do some kind of like inchworms here. And then again, the picture shows where there's 5 different points on the abdomen. And before I would have a patient take a deep breath in. And then as they exhale, I'm gently applying pressure to the abdomen. Then I'll move to the other spot. They'll take a deep breath in, just add a little bit of pressure in the center, breath in. And I would hit all 5 spots to kind of work on the abdomen. And again, if I have somebody who had, you know, any kind of gynecologic cancer, prostate, bladder, abdominal, I'll probably end up spending a lot more time in this region than maybe I would with a breast patient. If I'm going to move down to the legs, again, it kind of just depends on what your patient is presenting you with. And then for me, we'll just say that this is her affected side. So after I do the head, the neck, the sternal area, again, and you'll know if you need to spend a few more times somewhere else. I usually will come on the side of their trunk. And again, it's just these rotary stationary circles. And for my own body mechanics, I'm doing a lot of my own moving my legs around. But you don't want to just stand here and do this, and the next thing you know, you hurt your back or you hurt your arms. So then I just kind of get the side trunks. Same thing, it's just this kind of movement, circles, skin stretching. Again, just kind of prepping the area. So I probably don't spend as much time in this doing that as I will like treating her affected arm. And before I would have done this, I would have assessed her shoulder mobility. A lot of times when you can see, like, so when Sarah was standing, she's got good posture standing, but laying down, we can see she's a little bit more rounded here. And so then that's a good talking point for me that I might, you know, because a lot of times people can say, oh yeah, I've got good posture, and they sit up nice and tall, and then they lay down and you can really see how rounded they are. And then this will be another teaching moment where I'll just explain to them, you know, when they lay down, they're rounded, their arm is sitting more forward in their socket. Over time, that can create tightness and tension. I can get more of those knots kind of up in my upper traps up here. And then just, again, reiterating the importance of their posture and they're doing their stretches long term. A lot of times, people get through with all their treatment and they think they're finally done, and then they don't realize, like, over time things are going to get tight. And again, especially if any of this is fibrotic and they stop doing their stretches or they stop doing their posture, and you see them 2 months later and they're like, oh my gosh, why is my breast swollen? Why is my arm sore? What's happening? And they haven't been doing their exercises. So before I would have done all this, I would have assessed her shoulder joint mobility, just kind of done some just assessing and seeing if she has any issues in her shoulder itself that might need some other joint mobilizations, or again, some of that deeper tissue work. So after we do the neck, stomach, kind of the sides, the flanks, then we kind of do in the axilla itself. And again, it's these gentle circles. Again, for me, I find that if I can just use a bigger surface area, because realistically, we are scheduled 45 minutes to be with a patient. By the time you bring your patient in your room, you have a quick little discussion and you get to it, you're lucky to maybe get 40 minutes of actual hands-on work. So some of this stuff is abbreviated, and that's why figuring out that day, because every day will be a little bit different. Some days they might be more congested here or somewhere else, that you just have to focus on what feels like it needs the most work. So then we'll do right in the axilla. And again, it's just this skin stretching. And this is where we'll see a lot of that fibrotic scar tissue, maybe some cording. A lot of times I'll do a pin and stretch, or I'll take my hand here, pull their shoulder blade down, and kind of do some nice gentle stretches where I'm kind of, again, that tissue stretching, where I'm again directing everything, but it's light, gentle, where I can just open up their shoulder blades a little bit more. Because they find that, again, with breast patients, they get tight in their ribs. Maybe their drains were here and they're wondering why their drains are painful. And then I just explain, you know, the drains are in the intercostals. It's connective tissue. Drains, when you're moving around, can create that scar tissue, and sometimes it can be tender. So I might spend a lot of time on somebody's drain scar. So then
Let's get a couple questions, Amy.
Yep.
So
Yep.
just to confirm, they asked, where should we start manual lymphatic drainage first?
Neck.
In the neck. Okay. And how
Super particular.
sorry. Okay. And then how should we use it in breast cancer patients?
So this is like the sequence. So we're just, you would start with the neck, like we did, the abdomen, sides, and then, so I'm just going to assume she's a breast patient. So I'm right in the axilla, and this is where I would be working on her sides.
What I think is important too is that in subclinical lymphedema, you don't measure it. You cannot measure circumference differences in subclinical lymphedema. But if I have a breast cancer patient that comes in and tells me my arm feels heavy, my skin feels tight, my watch doesn't fit the same, but I don't notice any swelling, I'm going to start manual lymph drainage right then. So as soon as someone notices a subjective change, even though it's not measurable, I want to start manual lymph drainage along with exercise and compression.
Can you use it with cancer patients that do not have any symptoms yet of lymphedema in order to prevent?
There is a prevent study that looked at that. And they actually, in the study, it was published in November of 2022, and they looked at 11,000 people in the US that were at the highest risk of having breast cancer related lymphedema. And they used bioimpedance to detect subclinical lymphedema. And every person who showed with bioimpedance to have subclinical lymphedema, they actually started manual drainage and compression for 4 weeks. In those 11,000 people that they studied, the ones that received manual drainage and compression for 4 weeks were less likely to progress to stage 1 lymphedema.
How do you test?
Bioimpedance?
Yeah.
So that is, we use a 30-second electrical signal with a SOZO machine, which is actually, we have a breast cancer related lymphedema surveillance program here using a bioimpedance spectroscopy device, which is called SOZO. And we actually have the device here on campus that we use prior to surgery, after surgery, and then we follow these clients every 3 months, the ones that are at the greatest risk. And that information was actually was presented a year ago. So a lot of people who didn't see that presentation a year ago probably missed that information. But yeah, I'd love to go through that again as well.
And then they said, can the pressure that apply, is it gradient or proximal?
The pressure is, I like that question. I would say the direction of the pressure is going, is proximal. If you are pushing, you are skin stretching or wrinkling the skin towards central decongesting areas or proximal locations where the lymphatic system drains.
And should, excuse me, should you start from which side? Affected side or normal side?
Affected side. You always kind of do the head and neck sequence, then you always do the abdominal sequence, and then you get right to the affected side, because as Sarah had mentioned, the theory was that we would open up all the unaffected side and we would want to take the affected side and push it over to the unaffected side, but that research no longer is accurate. So that's why if you go online, you're going to see so many different things, because a lot of people aren't up to date on all of this research. So because we follow the latest research, we are staying on the same side. So we know that things are going to drain to the same axilla as for like a breast patient. If it's a leg patient, we still do the neck, the abdominal, and then we're going to focus on the groin, and then we're going to take everything from the affected side up to the groin and pelvis of that same side. So it's always the same side. And then it's always going proximal. And so a lot of times, sometimes I just revisit and I'll go back and kind of do another sweep of things. So if I've started in the axilla, and let's say I'm not just focused on breast edema and there's swelling in the arm, then I'm going to do that stationary circles and that skin stretching up this way. So I'm going to get on the lateral side of the shoulder. I'm going to get on the medial side of the arm. And again, I'm doing that kind of real gentle switching motion. Go ahead.
I don't
So
think
then,
that's a question.
so we got the shoulder, and then we'll do in the elbow. And I'm working my way down. And then we'll do forearm.
ผมให้ไปเหรียญนะคะ
พี่โจ
ขอบคุณค่ะ
Wrist. And then again,
ใช่
I think I muted you, Amy. Just a second.
okay, is that,
Yeah, and can I ask you a question while you're doing that? How do you have your patients dressed? Do they need thin clothes because of the light pressure?
So typically, since most of the patients that I see are breast patients, I actually have them take their shirt and bra off, and I'm directly on the skin. That's the most ideal. If somebody doesn't feel comfortable and you have to work through the clothes, you can, but ideally you want to feel and be on the skin. So I'll usually have like a towel here. And sometimes for breast swelling and breast edema, I'm actually working on the breast itself. If there's a lot of scar tissue here, or it's just thick and dense, I will do a lot of treatment where I'm actually on the breast. I'm moving things down this way. If there's an area that is thicker and harder, I'll spend more time in there. If they have scars on the breast, that can be a source of pain and be thick and hard, I'll do scar tissue mobilization with the scar, up and down on the scar. So sometimes I'm working like directly on the breast, but ideally you want to be on the skin. And then if somebody doesn't feel comfortable, and they might just take their arm out and then, they keep their bra and a tank top on. I can work around it. It's just patient preference. But for most people, they want you to work on these areas. They want you to kind of get in and around everything and use your hands right on the skin.
And it's interesting because I would say about 30% of people who undergo lumpectomy have residual breast edema. Even they can have lateral chest wall swelling. They often say that it feels like there's an extra pillow in between their arm and their chest. And but the problem is they're unlikely to talk to their surgical oncologist about it. And it's usually something that maybe their radiation oncologist notices, like, hey, I notice your breast is the tissue is really tight and full. let's send you to therapy because we can work on this. But for some reason, people they don't tell their surgeons, like, hey, my breast is really, really swollen. But 30% of people after lumpectomy experience residual breast swelling. And I think it's because of the location of the scar. For the lumpectomy, it's often right in the primary pathway of breast lymphatic drainage.
And that's why for this was the, let's say this was the breast that had the scars. That's better. A lot of times I'll just, I'll sit and I'll work. Again, if there's the scars are right here, I'll just do a lot of work where I'm just working on the scar, moving this down. So sometimes I might spend most of my session, I've had people come in who have had such thick scarring here. Arms are great, but their range of motion isn't really limited by their shoulder joint, but it's limited by this right here and their breast. That just when you start to work on that, it just can free up the arm itself. So that's where it'll be not that gentle skin, stretchy, what we think of as a classical stroke, but I might actually be getting in there and doing what I call is like a pin and a stretch where I'm moving the arm and then working on the tissue. So just kind of as far as it goes with the breast itself. So back to just the arm. So again, we did the neck, clavicle, abdominal. We've done the axilla. Now we've done the top part of the shoulder, the sides of the shoulder. We've gotten into the elbow now. We work on the forearm. We've got the wrist. We did all the fingers, thumb, in the hand. And then again, I might finish with just like some nice sweeping up. And then I might come back in here and do some more up in the neck. So that's kind of like a traditional, what we think of draining the arm. So then after I do that, what I usually will do will have the patient lie on their side. So again, this is her affected side, so I'll usually have them lie here. And then this is where we were assuming that maybe Sarah had that tight tension because of her rounded posture, because she has implants or had reconstruction, maybe she's tight in here. So this is where I might be able to feel that kind of tighter tissue. And then from here, I'll do a lot of lateral work because the pec muscle here tends to get really tight on people. So I'll kind of put my whole palm, hold it here, and then I'll gently just do some, again, of this kind of pin and stretching. Again, because we had mentioned they get tight in the ribs or they have that lateral breast, lateral trunk swelling. I'll do a lot of work here where I'm just kind of directing things. And a lot of times, honestly, I just go by how the tissue feels. If it feels like I put my hand this way, I put my hand that way. And you kind of, the more you start to do it, the more you can just sense where there needs to be work done. So a lot of times if somebody comes in after lumpectomy with breast swelling, I have them on their side and I do a lot of work on the breast here, right on their lateral trunk. And again, it's going to be, it'll be that gentle stretch, but some of it might be a little bit more deeper. Again, depending on if I'm working on fibrotic tissue that needs that little bit more scar tissue work, or am I just working on decongesting the area. And then a lot of times I'll put their arm here. And then if they have breast swelling here, I'm working right on the breast, kind of moving things here, if depending on, again, where is the scar, how thick is it? And then I'll do some kind of more kind of gentle moving things this way. And then again, when we talked about Sarah might have those knots in between her shoulder blades, I'll take my hand here, I'll put it under her arm, and I'll kind of see what her shoulder joint mobility is like. And this is where I might be able to work up and get these knots in here a little bit. I'll come back here and take this hand and I'll see, does she have some trigger points in between her shoulder blade? And I might do some shoulder blade work and just trying to mobilize her shoulder. Again, depending on if it feels like it's tight, then, so this is kind of where I get probably a little bit more deeper type tissue work, where I'm removing or working on the trigger points here. We have lymph nodes and lymph pathways down along the whole spine. So if I'm releasing that thick tissue tightness in these trigger points, it's just going to allow for things to flow. And if a person comes in and they're rounded and tight and they can't lift their arm, sometimes just me doing that shoulder blade motion, because again, sometimes people come in and they can't really move their arm separate from their shoulder blade, and they're moving things up this way. And if I just work a lot on the shoulder blade itself, they leave that day and they're able to put their arms up. I have people leave and they're like, oh my gosh, they can visibly see less swelling in their breasts. It doesn't feel as thick or hard. So again, it's a generalized routine, but it's not meant to be, it has to be this, 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 and this. Sometimes you're just going to have to go by how things feel, but it's a generalized kind of sequence. If somebody comes to me and they're so tight or they're pretty kyphotic and rounded, sometimes I'll have them go face down and I'll just do straight up trigger point work on their back and kind of work on muscle tightness that way. It doesn't happen too often, but sometimes people need it. And so I just go by how it feels kind of that day. So let's
Ask
so
two
that's
questions. Oh. Are you okay for me to interrupt
Yeah,
with
yeah.
questions? Okay. If the patient has a pacemaker implant, can you do this?
Yes.
And often they have ports. They have chemo ports that we work around as well.
Yeah. So yeah, often most people have the ports, and so you know around the neck you would work around the port or the pacemaker. If somebody, I've had a patient who got a pacemaker and came in and they can't reach their arms over 90, and so you just kind of work around things like that, but there is no contraindication to ports or pacemakers doing this kind of hands-on work. You just want to be careful of, if somebody came in and they had severe coronary artery disease or something going on in the neck, I sometimes will stay away from the neck region for other comorbidities where you don't really want to do a lot of neck work, but for the most part.
Yes, and then like an absolute contraindication would be if somebody came in with a cellulitis infection and you were like, hey, why is your arm red and hot today? And they're like, oh, that started last night, but I also feel like I have the flu, because cellulitis manifests often as flu-like symptoms. And I usually at that point, I'm like, hey, this looks like a cellulitis infection. I need you to go to immediate care because likely you need antibiotics. And so an acute cellulitis infection is an absolute contraindication. And DVTs, deep blood clots, deep venous blood clots. In fact, I had a patient a couple of weeks ago. I was working on her affected extremity, and she reached her other unaffected arm back, and that's when I noticed her other arm, unaffected arm, was really, really swollen. Remember, any oncologic process has some type of blood clotting effect. And so when she reached her arm back, I was like, hey, why is your unaffected extremity swollen? And she's like, it's not swollen. And I was like, yes, it is. I will measure you. It was 4 centimeters larger on her unaffected extremity. And I was like, you need to go to urgent care because something's going on. I thought maybe, I wasn't 100% sure. Most likely it was a DVT. And she did end up going, getting an order for an ultrasound. And she did have she actually had 2 DVTs in her unaffected extremity and was starting on blood thinners. So that's something else that we consider until they're undergoing treatment for DVTs, deep venous thrombosis. We don't, DVTs are a contraindication as well.
Okay, one other question. With manual lymphatic drainage, does it have a scapulothoracic mobilization as well?
Yes, absolutely. Well, in the traditional sense of manual lymph drainage, you probably won't see that on a video. But I believe, and I've had other training that's not been the traditional manual lymph drainage, that mobilizing the shoulder, the thoracic, whatever needs to be moved helps just with movement. And as we know with or lymphedema in general, we want people to be using their muscles. So if that means that we have to mobilize and get their ribs moving more, get them out of this poor posture, that they're going to be able to move their arms and walk and do things, I will definitely mobilize a shoulder, thoracic spine, if it feels like it's necessary. But if you were to go take a traditional class, you might not see that. But to me, it's all connected as far as fibrotic tissue, tight muscles, and the swelling. I look at it the whole big picture, and so that's why I do a lot of variations in my whole session that a patient will kind of probably say, I've been to somebody before and they don't quite do it that way, but I'm releasing a lot of other things that just help in general. So.
If I have, oh, sorry.
Go ahead. Is there another question?
If I have a bioimpedance device that measures body composition, can I use that as well for measuring lymphedema?
Yes. Yes. In fact, or actually, can you hear me okay?
Yeah, that was
Okay.
that was a question that I got from some of the leaders after they saw the SOZO at outpatient rehab.
Yes, the bioimpedance spectroscopy assigns an LDEX score, and the LDEX score is the lymphedema score. So an LDEX score of under 10 is considered within normal limits. Anything above 10 is considered lymphedema. But if we establish a baseline and someone is actually like a -5 at baseline prior to surgery, then if their score moves by 6, I start to get worried if their score moves by 6. So that would be if somebody's -5 at baseline and they move by 6, so they're 1, or if they move by 10, which would be 4, I'm going to call that lymphedema.
Perfect. And then can you see the other question? Can we apply in case of heart failure and swelling of both feet?
That is this is a great question. That's considered a relative contraindication, because if somebody is if their congestive heart failure is medically managed with medication, or they're being followed by a cardiologist who feels like it's safe to do manual lymph drainage, then we'll usually proceed. But if somebody if they come into your clinic and their legs are symmetric, if their skin is translucent, and you can see, because remember, lymphedema is subcutaneous. Cardiac edema tends to be, their skin looks really thin, their legs are symmetric. You wouldn't see that in a lymphedema. Then you start to think, hey, I think this is cardiac edema. It's probably related to congestive heart failure. Does this person know that that's potentially an issue? Usually I say, hey, this isn't normal. This wouldn't be a typical presentation of lymphedema. I'd like you to go back to your PCP and have some, or your physician, and I'd like you to have some more studies.
And kind of,
go ahead.
and kind of in the PowerPoint that you'll email to them, there's a slide that has the absolute contraindications and the relative contraindications in that PowerPoint.
Perfect.
And in the bioimpedance, if you have the bioimpedance machine, you can actually you can see where someone has an abnormal extracellular fluid and an abnormally less intracellular fluid. They don't have a risk of lymphedema, but they're being referred to for lymphedema, and that's when you maybe start to think, hey, this is either related to cardiac edema or renal failure. This is probably not something that I can address until they're medically managed. Okay.
So we'll, I'll just leave it.
Okay. I'm gonna leave my hand. Okay.
And then Sarah turned around and there was another question. You guys win the prize for the number of questions tonight too. What is the immediate effect after manual lymphatic drainage, and what patients should feel, or what happens?
I think most people tell me that they can, I mean, I have a patient right now who has a cardiac cancer, and he tells me when I work on his legs, because that's where he has most of his swelling, that he can actually feel things moving from his feet up his leg. So I have some people say they can actually feel things moving. I have some people say their eyes start to water and they just feel like things are moving throughout their whole body. But I think probably most of the time when people leave, they feel a sense of relief, relaxation in the muscles and in the tissue. Things don't feel tight. They don't feel constricted. And they walk out just feeling a sense of relief and relaxation. Sometimes people have to go to the bathroom as soon as they leave because they just feel like things are moving through. Even if I'm only working on just the arm or the breast, they just feel like better flow throughout their whole body. But usually most people leave feeling really good. People that I work on with their legs, a lot of times with the venous insufficiency, and again, imagine the fibrotic area in the arm. If you have that in the legs, I'll spend a lot more time in the legs, where we'll decongest in the groin, and then we'll decongest up the thigh, kind of around the knee, around the ankle, and then the foot. So if that same person that came in with the hand swelling from the breast comes in and they have this on the feet, and if it's fibrotic on their lower leg, I'll do a lot of work here. And I just this morning had a patient come in. He was a total knee replacement. He was wearing compression and then got an infection, so his doctors told him not to wear the compression anymore. And so last time I saw him, we got it much smaller, but then today when he came in over the last week, he wasn't as active as he was, because he's not supposed to wear his compression, which unfortunately I'm hoping just by what we're doing and him exercising, it'll get better. But over the weekend, he was at graduation. He was sitting a lot. He was active, doing yard work, but he didn't do any of his walking. And he's a total knee, and he's supposed to be walking, and so he thought he was active enough. But when he came in, his leg was very thick, hard, woody. It was right up in the calf here. And by the time he left, I just spent a lot of time on that tissue. It was softer and it was noticeably smaller. He had better range of motion in his knee and his ankle. So a lot of times my leg patients leave walking better, because I work on their ankle too if it needs it. But if they come in and their ankles are really swollen or their feet are swollen and they can't really move because of that restriction, or their knee, again with knee patients or just the venous insufficiency patients, they leave walking better. So they just feel better in general, I would say.
Okay, there's another question.
So I don't know my computer.
Yeah, I mean, it's still on.
Oh, Teams is on or something here.
So,
Oh, here, okay.
question: if patients have inflammation, can they use manual lymph drainage? It's interesting because we do see people with autoimmune conditions like rheumatoid arthritis that are referred to us, and they have maybe been tested for an autoimmune condition, but it's obvious to us, and we usually write the physicians back like, hey, let's do a panel, maybe looking for what is the rheumatoid factor, basically. But even those clients feel a relief with manual lymph drainage until they're medically managed for their autoimmune conditions as well. So yes, and even I love that question too, because here at OHSU, we are trying to study the incidence of chronic swelling after total knee replacement. So even our orthopedic team is involved using bioimpedance because we think that people with venous insufficiency have a higher incidence of chronic swelling after total knee replacements. And so we get a lot of those referrals that, hey, this person had some post-op swelling that didn't improve with PT and exercise. What are your next suggestions? So we'll usually start the manual lymph drainage with them as well. Post-operatively, I prefer to wait 3 weeks. If someone's had surgery before I start manual lymph drainage, I don't know if you have. I think 3 weeks is kind of the magic number, because if you look at the principles of tissue healing, in the first 3 weeks, everything is aggregating to the area to heal the tissue. Remember that? And so we don't want to interrupt the tissue healing process. But about 3 weeks time is when like the thrombokinase, everything is coming into that tissue to break down those healing tissue properties. And at that point, I feel comfortable starting manual lymph drainage. So I usually wait 3 weeks after surgery to start manual lymph drainage.
Did you see the technique to reduce pain as well?
Yes.
Do you see the other question?
Oh, no, sorry. Now I see it. Oh, see, oh, yeah, yes. So yes, can I do manual drainage immediately after breast surgery? I usually ask my patients to wait 3 weeks. Can this technique reduce pain? Manual lymph drainage is considered an analgesic. So yes, most people report pain relief after treatment. I tell my patients, like, hey, research says maybe you'll feel better for 4 to 6 hours afterwards, but usually anecdotally, my patients come back and they say I feel better 1 to 2 days after manual drainage. And I wonder if they probably tell you very similar. And then number 5, home program for patient and relative for another exercise. Yes, so all of manual drainage is just one component of complete decongestive care. So we usually have the clients, we can train a caregiver to do manual drainage, especially with head and neck treatments, cancer treatments. A lot of the spouses feel more comfortable treating that. So we can do, we train the caregivers, we train the patients to do their own manual drainage. We get them in compression, we talk to them about skin care, and we assign exercises to do. So those are the 4 components of lymphedema management.
I would probably say most of my patients that I send home with self manual lymph drainage, I talk most important to me is exercise and stretching and moving their muscles. And except for the head and neck cancer patients, they get so swollen and thick and hard right through here. A lot of times they have scars that come through here and down here, that when I'm doing their head and neck work, I'll teach them and the caregiver to do a lot of work right under their neck here and here. And they're probably the one population that I really emphasize their own work all day, because it just gets so thick and hard, and it can prevent or inhibit speaking, swallowing. And it's something that it's right here that they can just take their hands and kind of get here. It usually happens here, and so I have them do this and anything in here. For the the basic arm, breast, leg, a lot of times it's hard to do it yourself for a variety of reasons. So that's why I do a lot of education on exercise and using your own muscle pump. So I think Sarah and I both feel exercise and compression are at the top of the list, and then their own self manual lymph drainage, if it boils down to time in their day, and it came to those 3 things that we would probably reinforce: compression and exercise, and then their own manual lymph drainage. And so what we teach, so Sarah in her presentation had the pictures, but what I'll also teach is, because we're looking at that skin stretch that we had talked about. So if I just bend my elbow here, I'm skin stretching here. So just by doing some different movements, I can pump and move this fluid. And when I explain to the patients, like we're trying to get things moving everywhere, they tend to be, I think, more apt to do this little routine than spending 10, 15 minutes in the, I'll tell patients in the shower, specifically breast patients, they can do all of this stuff kind of in the shower. So they're, not strapped for time, but we also have, I think we sent it last year, that we have them start with 10 belly breaths. Again, we're trying to open up that area. And then I have them start at their head and do some head turns. Again, just by that skin stretch, I'm stimulating and opening everything here. I have them do 10 head turns, and we just work our way down. We do some shoulder shrugs here to get this area. I have them reach their arms up again, and in a way, I'm helping them do their range of motion. And so I'm getting in the armpit. I have them bend their elbows 10 times, bend their wrists, and open and close their hands. So I feel like I educate patients a lot, especially computer people, that they can just drain themselves throughout the day. And then to get to the abdomen or, the lower legs, I'll have them march, either sitting or in place, or just by kind of getting the groin, I'll have them straighten their legs out. Again, if they're sitting, to get everything behind the knee, and then just ankle pumps. And people are going to be more apt, I find, to do that throughout their day as a way of kind of their own manual lymph drainage of the whole system. And we have forms that we give patients to for that.
So, okay, these are such good questions that we really need like 2 more hours to discuss, guys. I wish we had that. Okay, there was a question number 6 in the chat. What to do if the patient already has lymphedema after axillary lymph node dissection? Basically, the goal of therapy is to prevent the progression of lymphedema. So if they're like in a stage 2 lymphedema, we want to make sure they don't progress to having like morphological skin changes or development of fibroadipose tissue. So we're going to continue to work on those 4 components within. We briefly talked last year that there are microvascular plastic surgeons who are now trying to reroute vascularly the areas of lymphatic dermal backflow to a local vein in the extremity. So that's called a lymphovenous anastomosis. So there are emerging surgical techniques to treat lymphedema. There's no cure, but we're finding better, more, because conservative treatments don't always work. And that's why surgical techniques have evolved. And then the last question that just came through is how can we differentiate lower limb edema between heart failure and venous insufficiency? With venous insufficiency, you'll see a lot of varicosities, especially on the dorsal feet, on the medial malleolus. You'll see a lot of superficial veins, because those are the collateral vessels trying to find a way to bring the fluid back up to the central cardiac circulation. And you'll see hemotherapy staining a lot with venous edema. So, and that kind of looks like a browning of the skin. And that's usually like a sock pattern, like somebody had a sock on their foot and it became discolored. It's kind of a gator distribution of hemotherapy staining. So you'll see that. Venous insufficiency is usually it's asymptomatic, asymmetric. So the limbs won't be the same size. One side is usually bigger than the other in a venous insufficiency, or maybe it's only unilateral swelling because maybe they had trauma on one side, like they had a crush injury on one side, which can still produce a venous insufficiency. And a venous insufficiency can actually lead to lymphatic impairment as well, especially if the lymph load exceeds the lymph capacity. because the vein is putting pressure on the lymphatic system. But with cardiac edema, it's going to be very translucent skin and it's going to be symmetric edema. And so usually that's how. So there's not as much discoloration with cardiac edema as there is with venous insufficiency. That could be a whole nother lecture, is treating.
I was gonna say, I think we could have you talk for a week, and that's what we want you to do eventually next year for the Center of Excellence in Lymphedema. So we'll have more for you on that. But that would mean a trip to Thailand, and then you should head off to Australia and start doing some research. There's a link to check out. Oh, that's for people to check out of the thing. The person who's been asking these amazing questions, I don't know if I've ever met, but amazing questions.
Agreed.
Well, we're at time, but I know you could talk for 4 more hours. I wanted to push your glasses up because those are brainiac responses always. No, because you're such a brain. You're so smart. And you guys look so great because we can see Amy sideways on yours, then we can see Amy straight. Like this worked out better than we've ever done a video. So
Oh, good.
yeah. Dr. Wanapa, are you still here? Dr. Sushila, are you still here?
Yes,
Can you
thanks,
close us
MD
out?
and Sarah for the answering all my questions because I asked directly to Connie and Sarah. Thanks.
Dr. Sushila, my favorite. So I'm going to get your PowerPoint, Sarah, right? And I have Amy's handouts. Should I also send them last year so they can see some of that? Would that be beneficial? Okay.
Yeah, that
Yes,
would make
yes.
far more sense if they saw last year's presentation first.
And that has the exercises too that complement the MLD.
Perfect. Dr. Wanapa, do you want them to come to Thailand?
Oh, yes, yes. Next year we have the cancer rehab, right? This is
That's,
definitely part of the cancer rehab. Very well
Yeah.
fit. Yes.
yep, these will be your 2 main travelers next year. Get
Thank
ready.
you. You are super planning in advance, even before our budget approval.
I just depend on you, Dr. Wanapa. So do you want to close us out, Dr. Wanapa?
Yes. Yes, please, please. Thank you very much. Thanks for everything.
Yeah, thank you, everyone. Thanks
Yeah.
so much, Amy and Sarah.